Hello, everybody, and a very warm welcome to today's Journal Club. We're delighted to have Dr. Beatriz Larru with us, and we're going to be talking about hospital onset bacteremia. Is it time for a new metric? And we'll come back to that question in a moment. Hi, Beatriz, how are you?
Hi, John. I'm very good. Thank you for inviting me.
All right, so let's just run through a little bit of background around Journal Club and what we're trying to achieve. So the idea is that we're looking to give some insight into a topical IPC published paper. We're really keen to generate discussion. The most interesting part of this for everybody is the questions that come in from you, the audience. So please do use the Q&A box for questions and the chat for more general comments. We're keen to provide opportunities for CPDs. This can become a learning environment to exercise critical skills, but also to build your confidence for independent study so you can go away and analyze a paper a bit more effectively. We want to have a network of enthusiasts and a little bit of fun as well. So these journal clubs are recorded and posted online after the event. So I'm going to stop sharing my slides, Beatriz, and perhaps you can get your slides sharing. But while you're doing that, I just wanted to ask a question, actually, because metrics for measuring healthcare-associated infection is something that's really close to my heart. It's something I've thought about a lot, and I know you have too, because you were trained in the US, and I had a lot of exposure to the US healthcare system in the early parts of my career. And in the US, they have a very different national surveillance framework that's very focused on broader healthcare-associated infections around CLABSI and CORTI and SSI and VAP, whereas our UK surveillance system is a bit more microbiology focused based on a smaller set of specific organisms. I wonder whether you can comment on why the difference exists and sort of the pros and cons of the different approaches.
Okay, so thank you. So I should start always saying, so I'm from Spain. This is my weird accent from Spain, but as John said, I trained in the States and I spent there 9 years of my career. And I do tend to get the good things that work in systems. I work in many places and in many different healthcare systems. And I think the surveillance system in the US has brought a lot of value for patient safety. I think that's what we have to. So this is a story of success of how actually learning what to count has made hospitals safer. So I'm very, well, maybe now not that much, but I'm very fond of all the, the CDC manuals and the CDC definitions because I think has brought a lot of value. And the fact that it was always seen as these things shouldn't exist. These things, should be you have to have a zero tolerance. You have to count, you have to know what to count, and you have to, the reality is that hospitals in the States will not get reimbursed sometimes for patients if they develop an HII. That has brought a lot of the improvement of the care of those patients and accepting that these things should not happen. No, so I think that's what I learned from the US system. It's very methodical. Everybody tries to use the same definition, so you can benchmark between hospitals, and that will drive improvement. I don't think, as we were talking before, I don't think the UK is not moving into that direction. When you think about the ranking of hospitals, there are metrics of healthcare-associated infections that have gone into that metric, into that matrix. And I think if we are able to have a voice and actually say what metrics should be incorporated there, we can bring up patient safety by counting hospital care, healthcare-associated infections. So I think that's what I like about the US system. I also think there is a lot of insight in microbiology of how UKSA does it. I think the story of MRSA in the UK is a successful story. Is how to, when you start counting them, you bring them down. I do a lot of working with my own data in aldehyde. So we are a standalone pediatric hospital in Liverpool to bring awareness of the metrics that UKSA ask us to report under the mandatory surveillance. They not always reflect what is happening in a pediatric hospital. And I do think I'm a huge advocate that, patient groups like children do need to be considered in a different way when you report for healthcare, safety. So I think both systems had good things, but it is what we will discuss today is actually knowing what to count, what makes a huge difference in patient safety.
Okay, thank you. So therefore, would some kind of amalgam of the US system focused on patient safety, remuneration, and kind of a broader set of healthcare-associated infection metrics, plus the microbiological approach of UKHA, maybe that's the optimal. We need to bring the two together. Maybe that's the nirvana.
Yeah, usually I found when I moved to the UK, like adapting some of the US concepts to the UK is probably what I have found the most benefit for the patients that I see today.
Yeah, interesting. Okay, I mean, I had an experience when I came to a new role in a new trust, and there was no eclampsia surveillance in critical care, at least that we could see at an organizational level, and it was a good thing to bring that in. So similar experience. Okay, Bea, enough. Let's hand over to you to hear about hospital onset bacteremia.
Yeah, so as I said, I'll try to present the paper in 15 minutes, but as you said, the most important thing will be the questions that this brings up. So the title of the paper that I selected is Evaluation of hospital onset bacteremia and fungaemia in the US as a potential healthcare quality measure and a cross-sectional study. And the reason I selected this paper is because it is very focused about bringing quality of the improvement, across, healthcare services, and how can we use this hospital onset bacteremia as a quality metric. So I'll refer to the study, and in the discussion, I'll also try to bring some of the points that the fabulous editorial that accompanies the paper was, bringing about the limitations of the usefulness of the paper. And I don't have any significant disclosures, but I have to say, if that works, why is not working? I'm convinced that if we know what to count, we can improve things. So I do believe that what gets measured, gets done. And that's how I try to approach IPC and what we do, what surveillance we do in this hospital. So the paper starts with a very nice introduction about what is hospital onset bacteremia. And for all of you, I mean, you probably already know, but so it refers to a metric that it includes all positive blood cultures, with bacteria, with fungus, but, that grows on day 4. So day 1 of admission is day 1 means the day of admission, and whatever grows in a blood culture bottle, it will be included in a hospital onset bacteremia in this paper, regardless of what results the patient has had in the first 3 days of admission. And the paper starts saying that, as we know, hospital onset bacteremia is being explored as an outcome measure for HIR surveillance, and we all know how actually surveillance is the cornerstone of IPC, and if you actually know what to count, you can improve the safety of patients. And it's also been proposed as a quality metric, as something that can be reported as a safety metric between hospitals. We know that hospital onset bacteremia is associated with mortality and with morbidity. We know that patients that have a bacteremia in hospitals will get antibiotics, will stay longer, will have a more complicated clinical course, and some of them will die. But what the paper starts saying in the introduction is the comparison between, a hospital onset bacteremia and a CLABSI metric. So as we all know, we are very familiar with the CLABSI definition. And as I said, most of us will use the CDC definition, but to really apply the CLABSI definition is not simple. You have to have a lot of manual chart, a manual review of the chart, the clinical, particularly if you don't have an electronic medical record. It's time consuming, it's resource intensive. We, for example, in Aldehe, we meet monthly. We only do the CLABSI surveillance in ICU, and we meet monthly, and it takes, an hour and a half of our time to go through the cases. It's not objective, even though it has technically an objective definition, there's a subjective interpretation of what is a secondary, source. Did the patient have another infection? So it's not fully black and white. The incident also, when you start working a lot on CLABSI prevention, your CLABSI rates will become very low. I just been in the CLABSI meeting in our ICU, and our rate is 1.6. So when you start going through a very low rate, it becomes more and more difficult to keep driving improvement, keep reducing the numbers. And it's also not that inclusive. So I only do CLABSI surveillance in ICU, and you are only focusing on patients that will have a central vascular access. So you're not focusing across all patients that are in your hospital. So these are mainly the criticism that has been done to use CLABSI as a solid metric for IPC purposes. So the paper starts, talking about, this group, the group that has done the paper that I'm presenting today. In 2016, they start publishing how the rate of hospital onset bacteremia and CLABSIs will be correlated in your hospital. And we've done that, for example, in Aldehe, and there's correlation. So, measuring hospital onset bacteremia instead of CLABSIs, you are still including the CLABSIs. And it also, you have more power to discriminate because you have more events. You are going to be able to try to, discriminate between different risk factors, and you can also compare between different hospitals where the rate of all hospitals go down in CLABSIs. So that was done by the same group, and the same group that, I wrote the paper that I'm presenting also, 3 years later, presented a paper, but it was a pilot study only with 60 patients in 3 academic hospitals. And they start talking about how many of these hospital-onset bacteremia events will be preventable. And what is actually also more important is that they start saying that not all of them will be counted. When you think about only count eclampsies, you are going to miss many of the hospital-onset bacteremia events. So only 20% of the hospital bacteremia events were considered eclampsies, and approximately, as I said, a third will be considered preventable. So, sorry, I'm trying to move and it's moving now. Okay, so that was also seen in the neonatal population. So this is a paper, again, published in JAMA, when you can see that actually in NICU, so this is a huge study, including, I think, more than 1 million babies, and they have almost 500,000 of NICU, and 2% of these infants will have a hospital-onset bacteremia. And as you can say, almost 55% of them, of the hospital-onset bacteremia in this NICU population, happen without a central line. These patients, if you only do CLABSI surveillance, you will miss them because they didn't have a central line, so they will not be included in your surveillance efforts. And there was a different mortality. So those babies that have a hospital-onset bacteremia die 5.5 times more than the babies that did not have a hospital-onset bacteremia. There's a different, several editorials about it, or how it's important to start counting all the events, not just CLABSIs, and how, CLABSIs and non-CLABSI hospital-onset bacteremia, they are all, they are associated with increased length of stay, increased cost, and a 3.5 increase on risk of mortality. So, with that introduction of what is the value of using hospital-onset bacteremia, is a more automatic, more simple, more easily to calculate, quicker metric of safety. This paper tried to have 3 objectives, and one of them was to determine the sources of a hospital-onset bacteremia in a large sample of hospitalized patients in the US, to estimate the proportion of hospital-onset bacteremias that are preventable, and to identify the risk factors, that are perceived with the preventability. And the reason this group, as I said, this group has been publishing, different years, different studies about hospital-onset bacteremia, is because if we're going to use it as a safety metric, we also need to know how to prevent it and, what sources are linked to it. So that was the whole aim of the paper, was to advance the understanding of the prevention opportunities of hospital-onset bacteremia, and informed and develop an appropriate subset of hospital-onset bacteremia that can be used as a quality metric. So the methods of the study, this is an observational cross-sectional study, and they really went in detail on chart review. And that's also a limitation of the study, but I will explain a bit how they did the chart review. This happens in 13 US hospitals. So all these hospitals were associated with 6 academic members of the CDC Prevention Epicenter program. And out of these 13 hospitals, 10 of them were academic, 3 of them were community hospitals. So they did try to include, not only academic centers. And out of the 10 academics, 3 of them were standalone, were freestanding, children's hospitals. So they tried to have the more diverse population that they could. What they did is that they asked, between 2016 and 2024, they asked for all hospital-onset bacteremia events, and they selected a random sample of hospital-onset bacteremia. They tried to get a sample of 2,000. That was the sample size that they calculated. And when they tried, they wanted to include a lot of community centers. So all these hospital-onset bacteremia events were divided between being a commensal, so if it grew, something that we will consider regularly a contaminant, and a non-commensal. And what they did is, out of these 2 lists, they sampled them randomly, and they got in a ratio of 1 to 5 adults and children. So they were 5 adults for 1 child, and they had as well commensals and non-commensal in a ratio. So for each 5 non-commensals, they have 1 commensal. And they include all non-commensals for community hospitals, because they wanted to diversify and not just make it a very academic-driven, large tertiary centers. So that's how they drove the sample size. And this is how they started doing, as I said, the chart review. So what they have a group of 3 types of people. So they have a medical resident, an infection diseases fellow, and an infection preventionist. They were trained to how go back to the medical record and what data they need to pick up to determine the source of the hospital-onset bacteremia. They went through in deep detail. They have a pro forma. They collected all this in red cap. And each center had also a secondary review. That reviewer was an infection diseases physician that had knowledge on IPC, and the secondary review was the one who determined if the episode was preventable or not. How they did that? So the preventability was in a Likert scale. They pointed 6, and this method had already been validated by the same group in the paper that I told you in 2019 when they published it. And they range all the events in being potentially preventable, or definitely not preventable if it was a 6. How they did the analysis is that they summarize, like the different characteristics of demographic and clinical between, like in the whole cohort. But they also started when the non-commensal hospital onset bacteremia events. They also look into what events have a positive microbiology culture 14 days before and 14 days after the index the index blood culture. They started looking into how the sources of hospital onset bacteremia were distributed, how many of them were preventable, and the way they did it is they used preventability as a dichotomous variable, so was preventable yes or no, and to develop like a hospital onset bacteremia as a quality metric, they did a logistic regression analysis to see what factors were were associated with being preventable, yes or no. But they also wanted to think about how hospital onset bacteremia relates with the current, surveillance system that we have in place. So they also say how many of the hospital onset bacteremia events were attributed to, as we said, the biggest categories that we already surveillance in the States, which is CLABSI, CAUTI, VABS, SSI, and MRSA bacteremias. So that's the methods of the paper, and we go into more detail into what about the result. So the result in these 13 academics, remember the sample size that they wanted to get, it was around 2,000 hospital onset bacteremia events. They went in 2,109, and you see the distribution, 83% of them were in adult hospital, 17% in pediatrics, and there was a community representation of 16%. I'm only going to show you here the difference and what is similar. So you see between children and adults. So children were more commonly, the children that have a hospital onset bacteremia, they were more common, have been admitted in ICU before. There was also the admission before for a child, before they have a hospital onset bacteremia, was a bit longer than for adults. The adults, had a much higher mortality, and they also have a longer, the kids have a longer length of stay. These are differences that we see regularly when in pediatrics, we compare cases series with adults, but the similarities, there was a lot of tertiary academic centers, so you can see that there was a lot of patients that were really sick. So there was a third of the cohort were on immunosuppressive. Most of them will have some medical device, and many of them will have been treated, 2/3 have been treated with antibiotics. So this is the description of the cohort. This is how, what the pathogens that were found in the hospital onset bacteremia events. So you can see that for the gram-positive, the majority of them, the most common one was Staph aureus, for gram-negative was E. coli, and for fungus was Candida. This is in the non-commensal, and in the commensal, as you can imagine, coagulase negative was the most common isolated pathogen. So if we think about the sources, so what was interesting in the non-commensal, so in these hospital onset bacteremia events that were not attributed to a contaminant, there was a lot of agreement between, the first review. Remember, these are the infection diseases fellow, the medical registrar, or the infection preventionist. When they were the ones who extracted the data, they presented to the secondary review, and most of them agree on the sources. They only did not agree on 5% of the cases. Most of the common sources were a gastrointestinal, source or an endovascular, and out of the gastrointestinal source, most of, a third of them will be because of a neutropenic translocation, will be what will be considered a mucosal barrier injury, for example, for the CLABSI definition. And out of the endovascular source, 2/3 have a central vascular catheter. So these were the most common source of the non-commensal hospital onset bacteremia. But it's significant to say that there was approximately 17% of the events, they couldn't find the source. They couldn't identify, neither the first reviewer or the second reviewer, what was the source. So if we think about the preventability, so I think for the non-commensal, 36% of them were considered preventable. These are episodes that, technically should not have happened. But if you think about a commensal hospital onset bacteremia, almost, 75% of them will be potentially preventable. Preventability was higher in community hospitals than in academic hospitals, and was higher in adults than compared to children. So I'll just quickly summarize this table because it's a lot of information on the table, but just to think for hospital onset bacteremia events that were attributed to either having a central vascular catheter, CAUTIs, SSI, or contaminants, these events were always perceived to be a higher odds of being preventable, while all these events that were, or there was no source, or was a GI source, or a bone, joint source, or polymicrobial, or there was a culture that was matching the index blood culture from the onset bacteremia in the 14 days before and 14 days after, these events were considered less preventable. So the conclusion of the paper was that, they studied almost 2,000 hospital onset bacteremia events out of 13 hospitals to try to solidify the use of hospital onset bacteremia as a healthcare quality measure. Out of them, I will, highlight in red, 36% of the non-commensal hospital-onset bacteraemia events were rated as potentially preventable. 40% of these potentially preventable will not be included if you just focus on CLABSI, surveillance. Out of the ones that grew a commensal organism, almost 75% of them were considered preventable. And therefore, they pose that hospital-onset bacteremia can be used as a quality metric if, and we have to understand better, how to exclude non-preventable events and adjust it for the risk population that you have in your hospital to use it as a quality metric. And as I said, the study also has limitations. So it's quite how generalizable is when it only includes US hospitals, is mainly including academic large tertiary centers. There's a subjectivity, it's always prone. If you think about how when you review episodes that have gone wrong for the patient, you always think that they will be more preventable. If you review episodes that have not caused harm, you might not see how more things that you could have done different. There's always a limitation when you use retrospective medical records, and it's also true that they did not include things that happened before the patient comes into the hospital, which we know now drives a lot of the importance for the preventability. As I said quickly at the beginning, this is also the editorial that brings up with the paper. And the editorial brings very good points about, how we actually now need to develop also guidance of how to prevent not just CLABSIs, but hospital-onset bacteremia, because if not, we'll have a metric that is easier, that everybody can implement. This doesn't have to have line days, it's much easier to get. But if you don't know how to prevent it, you're just left out with something that you cannot use. But it's a robust metric that can improve and can, identify new targets where we can, improve and provide better care. And with that, I will just say thank you. And as I said, the most interesting part is the discussion of the paper. So thank you very much.
Thank you, Paia. That was brilliant. Really fantastic overview of the study, and good to see both the strengths and limitations captured. It's a huge undertaking. I mean, it must have taken them a long time to go through all those cases in such a systematic way across all those sites and pull it together into a coherent piece. So can I just start with a question about preventability and the assessment of preventability, because it strikes me that it's essentially subjective, as in, it's a clinical judgment based on the patient picture as to whether it's preventable or not. So how good a job do you think they did to standardize that decision making around preventability?
So the appendix, which I should have probably put it on, the appendix has a very detail of what did they consider that was preventable or not. They give examples of, extractions of the medical record. So I thought the same. I thought, well, when I meet with my ICU colleagues, I sometimes say factors that for me are preventable, but they always bring, well, we cannot do this in the patient because of that reason, But a lot of the preventability were lines that were not used, which we all will agree that if you don't need the line, why? So that was a huge factor of preventability. And if you, at least that happens in my hospital. So we do try to review lines every day, but that doesn't happen all the time. Preventability was also a lot of medications that could have been given oral that were given IV. Preventability was also a lot of times of accessing the lines that could have been grouped. So yeah, I always think of the preventability. Well, this child does not have. Do you think of the child that has no access, or at least I only think of. Sorry, I always refer to pediatric patients, but the child that doesn't have access and needs and is on TPN 24/7, and if you don't give him TPN for a minute, it drops the glucose. But the reality is that there's a lot of them were preventable just because the line was not purely needed. So that was the ones that all went into the agreement. There was also the ones that, and I think the paper brought a very good of GI. So GI was a source in hospital-onset bacteremia in a third of the cases.
Yeah.
And out of this GI, I find in them particularly the most difficult group for me to prevent. The ones that have either a short gut or have gone for surgery and they translocate.
Yeah.
But we know for the papers, we know from other, groups that also doing horizontal measures of, using daily baths, that will decrease your rate of all hospital-onset bacteremia. So sometimes I get challenged, and this is what I enjoy most about when I do my job. When I think that something that I think is true, it becomes not true. And when I think, it's no way you are going to prevent a child that has a short gut, that is translocated, well, actually, that's not fully true. There are also things that you can do that will prevent it down. And I think if we will focus more on a hospital onset bacteremia just than on CLABSIs, we will be able to think about, is decontamination of the gut helpful? Is introducing early feeding helpful? But these things do not always get counted as a CLABSI, and therefore I think there's less incentive to know how to prevent it. I don't know if I answered the question or if I talk. I'm so sorry.
No, it's a good question. So I think fundamentally, I think they did a pretty good job of making what is essentially a subjective clinical judgment as objective as possible through the kind of rigorous steps in the protocol with the first and second reviewer, and then the specialist review as well. I was going to ask about GI sources and gut translocation as well, because that's something I've come across and heard a lot of people say, oh, well, it's gut translocation, there's no way we're going to prevent that. But it's interesting to hear you say that's not always the case. I mean, do you have in your mind what sort of proportion of the hospital onset bacteremias that were non-commensal were considered preventable even with a GI source? Do you know, was it like 1% or 50%?
So I think I'm just going to put again, they thought that 36% of the non-commensals were considered preventable. And if you think of 36%, it's like approximately a third of the non-commensals were because of a GI source. So you will think that approximately around 10%.
So like a third of a third.
Exactly. And I think that brings very nicely. I always like to link one event of IPC Partner with the next. So remember that one we have last few weeks ago with with our Jessica Martin talking about water.
Yeah.
So I think, yes, I mean, some of them will be translocation, but some of them is also transmission of gram-negatives in your unit.
Yeah.
So I think what I like about the paper and the concept of a hospital onset bacteremia is as an inclusive. You include all of them. I agree that they not all have the same meaning. The commensals versus non-commensals, they have different roots, but if you think, for example, of, I don't know in your hospital, but in our hospital, at least in Aldehe, we have a huge rate of contaminants on blood cultures.
Yes.
Okay. If you think about, by the time you know it's a contaminant, the child has already received antibiotics, the child has already repeatable. So the harm in a way has been done. I understand they will have less clinical severity, but it doesn't go without harm that a child gets a contaminant. So I do think I like the paper because it brings up that interventions in IPC cannot be just focused on one particular group. You have to think about more broadly to be able to bring up the quality to everybody.
It's almost as if you've read my notes, Bea, because my next question was going to be about contaminants and the kind of commensal story and what the findings were there, because it's something I've been looking into recently. And exactly as you say, whilst commensals are often, or contaminants are often dismissed as non-significant, they are clinically, but actually the impact they have is significant. So overall picture, what proportion of the hospital onset bacteremia were considered to be contaminants? I can't quite remember the figure.
So out of them, sorry, I should put back the slide. So out of the comments, let me just bring it up completely, the second page. So for the non-commensals, the number of commensals were like 320 cases. So then there was out of the total, which was 2,000, and the ones that were commensals were like 320 cases. So, but there was in the series there was like 10% of them were polymicrobial. So there was 25% of the patients that have a hospital onset bacteremia will have a positive micro 14 days before, 14 days after.
Yeah.
So there's but they remember that they tried to also modify the sampling. So they did the ratio of 1:5 because they wanted really to. So I don't think you can use these events as a rate of contaminants. It's just they modify the sample for they sample it strategically to get a ratio of 1:5.
I'm pleased you reminded me of that, because I was just about to say that's a 16% contamination rate, which is really high, but actually it's not, because they modified the proportion for the purposes of the study. Okay, that makes sense. Okay, so now they used a day 4 cutoff as the kind of fundamental point at which after which they consider a hospital onset. That feels quite late into a hospital stay for me. Is there any evidence or rationale around a day 3 or even a day 2 cutoff?
But remember, day one, I always get the same thing. So day one was well, I count as day zero. So I usually do, when I do all the metrics of hospital, of healthcare associated, I always say, okay, day of admission is day zero. And if day 3, you become a healthcare associated, like I give the 48 hours. They have the 72 hour, I think, metric. I'm not sure that is that much of a difference using 48 hours or 72 hours, because for example, when I review our eclampsia, they tend to happen more at day 11-ish. And if you think about how long the patients were admitted before, the kids were admitted 14 days before. So I always thought the same. Why don't you use, why don't we agree all of that universally to say day 3 and your day, but I guess there is always, you can consider 48 hours or 72 hours.
Yeah, interesting. Okay. So good question from Carla here, from the audience. So when you reviewed the central line charts for line necessity, was there also a check as to whether the required ongoing monitoring and care bundle documentation, so ongoing line care, have been done as well?
So we can share the supplementary. I don't think that's in the detail of, I read the whole supplementary, and I don't think, Carla, that was explicitly explained on the supplementary material. And only because I work in the States for a long time, as I said, most of the kids that will have they have a central line, they have a very clear, so the bundle is incorporated in the electronic medical record, so you can actually see when you do the rounds if the bundle had been met, yes or no. But I work in very large hospitals that have very targeted and sophisticated electronic medical records, so that might not be universal in all the centers in the States.
Okay. Yeah. So I was going to think about the kind of idea of the electronic patient record and how that might change the dynamic slightly, because your rationale at the start for going down the route of hospital onset bacteremia rather than a more targeted metric like CLABSI, which is probably kind of more specific as a preventable infection indicator, obviously. Yeah. Was that it's hard to get accurate CLABSI data. Does the advent of an electronic medical record combined with automated algorithms and semi-automated algorithms to more effectively pick out your CLABSIs change that dynamic slightly?
So I have to be careful because this is recorded and I don't want any, but at least I can say what I know from Aldehe. So it's pretty difficult to have a accurate assessment of line days. It's pretty difficult.
Okay.
I can, so with a bit of work, but I can see how many lines they are on ICU, but knowing when the line was placed, when the line was removed. So when we do the CLABSI, we spend quite a lot of time, and I'm with an intensivist that knows how to use Badger very much better than me. And the documentation is pretty good when they get it in the line, but the removal of the line is not always documented on the medical record. It also becomes more complicated if more groups can. So if you can have a line because it's played by surgery, or a line that is placed in theater, or a line that is not always. So I completely agree. Having an electronic medical record, I should be able, as a DIPSI today, to immediately answer the question: how many of my patients admitted today have a line? How many of them have a Foley? How many of them? I don't know that info. I will like, for example, that our rounds starts with the medical devices. We'll start doing the IPC rounds for those ones that we know are going to have more chances to have a hospital-acquired infection. But that is not an information that you get clinically meaningful from the medical. We have everybody complains here about the medical record system that we have. I will only say that we don't have EPIC. I won't mention the one we have. But it is really difficult. And it's not user-friendly. Our intensivists have to manually now have the nurses have to count the days that the line had been on. And when they do the rounds and they review, do you need that line, yes or no? We need to intensify that question after day, 7, 10. And it has to be done, by the nurses, because the electronic medical record doesn't not allow me to put an alert that, when you do the round and you review that chart, you understand that that child is moving into the high risk of developing an infection because of the length of time that has had medical devices. So I'm not 100% sure that having an electronic medical record always, is equivalent to be able to do the CLABSI. You still need to do a lot of work. And what we do, for example, for line days is that we surveillance the unit, in 3 days per week, and we get the median of those 3, like we validated a few days, and we know that doing it, 3 times per week for now is giving us a relatively steady, denominator.
Okay, great. So question from Carla here around ongoing care of lines. So we did the study mention a scoring system for looking after lines when they should be removed or changed, and whether there was any kind of assessment of compliance with good practice around line care?
So again, this is, I mean, it's routine practice of, like only knowing the centers that they did the study, I will assume that that's part of the daily review of the bundle. So, you have your insertion bundle, you have your maintenance bundle, and that's the most important thing of almost of your maintenance bundle. So I will imagine that is included. But they were not, there was not the bundle, for example, was not included in the supplemental material.
Okay, let me take a slightly different angle now, Bea. So thinking about how this might be applied in practice, if we decided, yes, we are going to use hospital onset bacteremia as a quality metric, and we then begin to say, one of our ICUs at one of our sites has an unusually high rate of hospital onset bacteremia. We're going to take that data to the clinical team and try and understand what's going wrong. And the clinical team come back, and as you will have experienced many times, Bea, the first response is always the data's wrong. And that would be the case in this scenario too. And they might say, hospital onset bacteremia is such a blunt instrument. It's too high level. It's not a useful and specific. The indicator is not specific enough for you to be telling us we've got a high rate that is modifiable. How do you think you'd manage that scenario?
So first of all, that's
sorry,
not
this feels like a job interview. It's not
I know,
a job.
I feel like I didn't develop the hospital onset bacteremia, but I have to say that is, I don't know if that not happens to you when you do the CLAPSI. So I do the CLAPSI meeting, and usually over the following week, I have a lot of, that's not a CLAPSI because that patient haven't, so there's also the subjective bit. Well, I think hospital onset bacteremia is much less subjective, and therefore, it's the day you get the blood culture. So I agree with you, and that's what I think this paper brings a lot of value of the hospital onset bacteremia as a quality metric. I don't think you can treat commensals and non-commensals the same, even though we all agree that understanding the harm that for patients to having a contaminant at least for kids, it's not without any, any patient, side effect. You sometimes you have a blood culture, the child is already home, you have to bring them back. You have to, if you want, you have to do some rapid identification in the lab. So, but okay, fair enough. A contaminant will have less clinical damage for that patient, fair. So I think what this group has started to do is that you need to not just report hospital onset bacteremia, you need to also do it between commensals and non-commensals. One thing that this paper did, which I think is very interesting, is understood that if you have, so how you can, when you start thinking about the rates, how many times you count a patient when the patient has multiple, bacteremia. Kids that are in the ICU for a long time, they will have more than one episode. And they filter out that if a patient has multiple episodes, there's also something that brings a lot of the intrinsic risk of that patient, not so much about the safety of the unit. So you might want to count them only one, for your metric. So I do think that there's work to be done still with the hospital onset bacteremia. I think this paper brings enormous benefit of understanding how this can be used as a quality metric. And it also, one thing that I didn't know, and I learned in the paper, is that when you think about getting into the 25-30% of preventability, it looks at things that you can include as a safety metric, like readmission rate, mortality. All these metrics go into the 25-30. So they bring also that how using this as a quality metric, I think is more objective. I think I spend sometimes more time trying to get line days than actually talking to ICU about how to prevent the next one. So when the metric becomes an end rather than a tool to improve safety, I think that's a problem. And also when you bring down so little, when we have 7 episodes of CLAPSI last year in my ICU. Well, from 7 to 5, is this a big of a difference?
Yeah.
So when you go into that,
it's big, but is it real?
Yeah. So we count now days without a CLAPSI, we do it by days because that's more meaningful. We want to get into the, 5 months. We want to get into because the total number brings less improvement because we believe that we are already there. And I think that's the problem of metrics, that when you believe that you have arrived, you stop improving.
Yeah, that's it's really interesting. Okay, so you've talked about central lines and their association with BSIs. you did mention, or the authors looked at peripheral lines as a risk, and obviously peripheral lines are far more numerous as a risk factor across an organisation. So, what's the story around peripheral line associated hospital onset bacteremia in the paper? Did that come out as a strong predictor of hospital onset bacteremia?
And in the conclusions, I mean, I should probably not have gone that quickly in the conclusions, but they said 40% of these hospital onset bacteremia will not be included in the CLABSI surveillance. So 40%. Yeah. And if you think about that, I don't know in adults, sorry, but for example, for neonates, that's actually quite important. So most of the neonates will not have technically a central line, will have a long line. Some of these lines are not. Okay. I mean, and I have a lovely ICU colleagues. It's not that my unit is, but they were saying, well, we don't place lines. We won't have CLABSIs because we don't place central line. We put, like mid lines. And well, if a patient gets a bacteremia, that patient is going to stay longer in the unit, have a risk of mortality, consume antibiotics. So, yeah, it will not be in the numerator of the CLABSI, but it will be in the numerator of harm. And I think that's why this paper brings up. But it's 40% of them will not be counted. In groups like neonates, as I said, that they use the central line use is lower. It was 55% on the JAMA paper that will not be included. It's 1 in 2.
Yeah. Amazing. Okay, two more quick questions then. So if we're looking at kind of intra-hospital or inter-hospital comparison, what would be an appropriate denominator for your hospital onset bacteremia numerator? Would you go back? You can't go back to line days because not all of them have lines. What's
patient days? When they comparison is, and that's how they, so far in the States, the hospital onset bacteremia is a voluntary metric. They're not, it's not mandatory. It probably, maybe with a bit of time and understanding of the metric will become, I will think so, they will become mandatory, but for now but it will be patient days.
Okay. Question from Brid: was there any association between chest tube insertion and bacteremia? Was that one of the risk factors that came out?
No, not in the tables. I mean, as I said, I can review again and I put my email. I'm happy to share the appendix. I mean, it's actually in the internet. In the appendix have quite a method, but not that it was chest tube. It was more endovascular. Most of the endovascular were because having a central vascular catheter.
Okay. So look, we are nearly out of time. I've just got one more kind of question for you, which is, I suppose, the ultimate question based on what you've been talking about. Hospital onset bacteremia as a surveillance system, yes or no? Should we do it? Should we implement this as a supplementary surveillance system locally?
I think so. I think surveillance has to be able to be automatized, be quick, easy, and we should spend more time preventing than counting. So I think for me, yes. For me, it's a yes.
Okay, brilliant. Bea, thank you so much. That was fascinating. I really enjoyed that. I hope others did too. Let me just let you know about what's next in terms of our IPC Partners Journal Clubs and webinars. So in a couple of weeks' time after Easter, we have got, we'll be joined by Kerry Holden for an insight webinar in partnership with the Healthcare Infection Society and the Healthcare Infection Society in IPS, talking about addressing healthcare inequalities in IPC. So that will be a very interesting session, and you can register using the QR code there. Just a reminder that the live schedule of Journal Clubs and Insight webinars is available on the website there if you scan that QR code. And finally, all of the Journal Clubs and Insight webinars are available on the YouTube channel via that QR code there. So just a final thank you to Bea for joining us today and for your insight and such an interesting Journal Club. And thank you to everybody who's been able to join us today. And we hope to see you again soon. Thank you.